Welcome everybody. Today we're going to take an opportunity to look at chest compression only CPR. And by the time we get done with this, I hope you'll be able to have some insight as to why chest compression only can actually be a better treatment than the traditional 30 to 2. But keep in mind, there are certain things we got to look at in those cases. I would never recommend an infant or a child, hey, let's do compression only for them. Those are certainly two groups of patients that we should try and be ventilating if we can. But it's some interesting information as we go through. Think of this mostly as a review as your traditional CPR. There's some spots in here which don't include all of the appropriate compression rate, depth, and recoil landmarks that you may be familiar with. So this is something that can really be utilized outside of your professional setting, unless of course your medical director has said, hey, you guys are doing compression only CPR. Maybe compression only with some form of passive oxygenation, such as a non-rebreather that's placed on their face. But whatever those protocols are, this is certainly not to change that. It's just to look and get us thinking, hey, why are compressions good in the first place? What's going on with the heart? And those are certainly things that I'm going to address with you today. So sudden cardiac arrest, when we think about this is any age, anybody. And that's what this list is telling you. We can erase these 4 names and you can put 4 different patients with, the same age on them and just some different circumstances. But keep in mind, sudden cardiac arrest can happen at any time and any place, and unfortunately to any patient. The common causes of death in the US, just kind of as a review, that heart disease, number 1. It's been number 1 for a long time. And what's shocking about this is if you look at that, 325,000 people, okay, outside of a hospital suffer that cardiac arrest. And then we do the survival rate on that, 8 times 3, 24. So what is that? Approximately 26,000 people will actually survive that. 26,000 out of 325. So why are those numbers so low? Is there something we can do as lay people or in the public? Not necessarily when you're working on that 911. So let's kind of see fact and fiction for cardiac arrest. And it's always this typical, oh, it's got to be, it's a man, he's overweight, lives a sedentary lifestyle, may have had a history of heart attacks. But in reality, it's almost equal male and female. Any age, and typically we're talking for an adult, and that is anyone past the point of puberty for the AHA protocols. Not a history of those risk factors as you may expect. And oftentimes there's no cardiac history again. And so as we start to look at the difference between the sudden cardiac arrest versus a secondary cardiac arrest, I think some of these things will start to make sense and be really clear. So here's the heart attack versus cardiac arrest first, right? Heart attack means you're conscious, you're in some type of chest discomfort or pain. I'm going to say it always presents with the jaw or the left arm, because as we know in females, it could be the low back, the shoulder blades, or even what is known as a silent MI. Now, cardiac arrest, on the other hand, the heart stops. Well, does it stop? If it does stop, fill in the blank. The heart that produces no electrical activity is in a rhythm known as asystole. Yay, give yourself a point if you got that. Now, the 2 most common rhythms that we see in the heart during cardiac arrest are, fill in the blank, ventricular fibrillation or ventricular tachycardia. Both of those are bad because that heart's either pumping so fast or it's such an erratic rhythm, it doesn't have that preload coming in from the atria. It's just the ventricles that are actually firing at that point. So big difference. Heart attack, conscious, cardiac arrest, they're out. Now, often a cardiac arrest occurs due to a heart attack. Okay, that makes sense. Now, primary versus secondary cardiac arrest. And this is going to have a lot to do with why that compression only is appropriate in this setting. So in the primary cardiac arrest, the heart stops pumping. Again, VFib or VTAC, potentially asystole. Now, when that happens, that person was breathing just a second ago, right? Think about this and look at the difference in the secondary cardiac arrest. It's a drowning, a drug overdose, choking. Let's add one more to it, carbon monoxide. Carbon monoxide, again, that person's going to stop breathing first, and then that heart rate can actually follow. So in that example, that person's been deprived of oxygen for multiple minutes before help arrives, right? Someone's at the bottom of the pool, maybe it's 4 or 5 minutes before someone notices, right? But you see the difference in those two types of arrest. I'm sitting right here, and I go down, right? Immediately preceding that event, I was breathing, I was oxygenating, I was ventilating. All those things are different in the primary versus secondary cardiac arrest. Out of hospital cardiac arrest, again, let's think about yourselves as lay responders, not necessarily in the EMT or the paramedic scope at this particular time, but 70 to 80%, again, of those 325,000 people, what does that put us up to? 275,000? Those are primary cardiac arrest, or what was referred to earlier as the sudden cardiac arrest. Chest compression, only CPR. And that's good information, but why? You know, the whys behind this are what becomes so important. So in looking what chest compression only is, it's kind of in the name, right? All you're doing is chest compressions. But while you're doing chest compressions, there's still that form of passive oxygenation which is created. Right? When you press down on the chest, what happens to the air in the lungs? Well, it's going to exit. And then as you allow for that recoil, or you take that pressure off, you're at least taking in that 21% oxygen that's in the room air. Now, as far as the research goes on this and the Sarver heart model from the University of Arizona, it's been a little longer than 10 years. These slides are probably about 2 years old when the state actually put them on. But they're a great resource to be able to go through and look at this. And there's a couple others that I should have the ability to pull up, just so you know where there's some additional training, just to kind of keep your brain processing and working while we get through all of this. So continuous forceful chest compressions. Okay, I'm gonna pick that one apart for a sec. Chest compressions are done hard and fast, but there's certain parameters that we have to keep in mind. And these are 4 things that I may ask you to recall later: the placement, the rate, the depth, and the recoil. And as I looked through these, they don't really address the recoil as you're doing it. The rate may be a little slow, but those are things as experienced or at least CPR certified students that you should be able to say, hey, what about this and that? Remember when I took my CPR class, we made sure we did this, that, this, and that. So we can kind of pick this and choose where it's appropriate for us. But why isn't rescue breathing necessary? Again, why isn't rescue breathing necessary in a sudden cardiac arrest with an adult? Lungs are full of air. Blood is full of oxygen. Now, your primary goal at that point is, as you do compressions, right? You're pulling that blood through the superior and inferior vena cava, starts to make its way through the heart, and eventually, as you continue pumping hard enough, it'll come out the aorta and then trickle up to the brain. Right? This is all about making sure we keep that brain alive. As you remember, and I don't remember the chapter, I apologize for that, there's this little time window, and you can see that how long does it take the brain to be deprived of oxygen before it's going to be nothing. And most studies will tell you somewhere between 4 and 6 minutes. You know, potentially it's longer if they're a cold water drowning victim, but we want to get started with compressions as soon as we can. It's an interesting concept about why rescue breathing may actually be harmful. So the biggest one you're going to see is what's bulleted as the first point, is that as you interrupt compressions, that's interrupting blood flow going to the brain. The AHA standards do give you a certain amount of time to deliver your 2 breaths. So here's another pop quiz. What is the maximum amount of time it should take someone to deliver 2 breaths for any patient? 10 seconds. Hey, give yourself another point if you got that correct. Increased pressure in the chest, decreases blood flow return to the heart. So what can actually happen is as you hyperinflate or you overinflate those lungs, it can actually start to impinge on the superior and the inferior vena cava, so making less blood available for circulation. And that's kind of a cool concept when you think about it. You can provide too much breath, expanding those lungs, which decreases the amount of blood that's available for circulation. Some of the other problems that I did not see on here, but were certainly on your AHA test, if that's the CPR you have with us, is one of the larger issues is creating gastric inflation or gastric distension. And when you put too much air into the chest, a lot of that can come back, trickle down the esophagus, gets to the stomach, and then the patient ends up vomiting. And then are you really going to be giving breaths to someone who, yeah. So again, when we talk about breaths or we do that with the traditional CPR, your amount is just enough to make the chest rise. And it's even better if you've got a bag valve mask, pocket mask, something with the supplemental oxygen that we can attach to it. This is probably my favorite slide. When you look at the chest compression only at the top, look how many millimeters of mercury that you're actually able to create. Now, down here, we notice that we are getting some pretty good millimeters of mercury, but look, there's this gap. And then here's another gap, right? And think about what is the point when you're doing compressions. Compressions are about oxygen moving to the brain. There's this idea out there that chest compression only or compressions in breath can actually restart someone's heart. Sorry, the only way that's going to happen is with defibrillation. VVIV and VTAC will respond well, the sooner we do that, to defibrillation. Compressions just move oxygen up to the brain. In order to fix the heart, we need this other tool that's called the AED. So, but look at the difference. Would you rather have your brain supplied with this oxygen or with this one? Again, and we kind of think of it in that regard, maybe you'll know why those chest compressions could be appropriate to only do the chest compressions. What stops people from doing CPR? Well, what stops you from doing CPR? Let's hope nothing, right? This is your job. This is what you do. This is what you signed up for. There are some concerns, and this is certainly one of them, mouth to mouth, right? I can look at your skill sheet. That does not show up as well when I'm sitting here on the beach, but I will read you the first page or the first point possible from your cardiac arrest management AED station. Take or verbalize appropriate PPE. Okay. Is mouth to mouth really something that's going to generate that ability to keep you safe? I'm going to opt out on that one. So chest compression only. Again, in the work setting, you've got bag valve masks, pocket masks, and oxygen tanks, which are awesome. Harming the person, that's one I hear a lot of, right? Am I going to hurt this person? Okay, homie, you already checked them out. You're not breathing. There's no pulse. So what is that person? And this is where you fill in the blank and say that person's dead or obviously dying, but our job is to fix that. So you're not going to harm the person unless you do something less ipsa loquitur, which means the evidence speaks for itself, right? You can't cut a hole in their throat. You can't try and breathe for them that way unless, of course, that is your scope of practice. So harming the person, I understand that. I taught a lot of classes where people are like, well, what if I do this and that? Okay, well, they're still dead. So keep doing the best you can, right? Oxygen going to the brain. Legal consequences, well, the Good Samaritan law does cover the lay responder for something like that. It will not cover the I did something stupid, right? So this is all about staying within your scope of practice. Won't perform it properly. This is why we practice. Physically unable, I understand that, right? Lady, 98 years old, happens to be married to a 56-year-old. The 56-year-old goes down. This lady gets her walker and comes over and can't do it. Okay, call 911, right? Early access. early CPR, early defibrillation combined with advanced care, as well as the definitive care, getting this person to the hospital, those are your links in the chain of survival. So if you are unable to do compressions for any reason, hopefully those will be minimal at best, but call 911. Right? Better than dead. Oh, the solution. So what this is saying is mouth to mouth, do chest compression only. Sure. Harming the person, it is better than dead. Good Samaritan law, easier to do. And do your best, call for help. When to use chest compression only CPR? Someone who unexpectedly collapses and is unresponsive, right? When you look at that, that's the vast majority. I get a lot of people ask me, well, what if this and this and this and this? I don't know, right? You've got so many variables thrown in there. Each scene is completely different. So as long as you follow that template or algorithm of, I'm going to keep myself safe. Hey, I'm going to check this person, call 911. Great. So don't worry about all those what ifs with this. Traditional CPR, and these are where your standards come in, drowning, choking, drug overdose. Yes, children as well as infants are involved with this, but also the carbon monoxide poisoning. So those are all things which will take away that person's ability to breathe first and then shut down the heart. But if you have any doubt, and this is something that we teach as well, what if I didn't feel a pulse or I wasn't sure if I felt a pulse? Start CPR, right? It's that important to keep that oxygen moving to the brain. And then the question comes up, well, then are we doing compressions on someone who may actually have a heartbeat? Yeah. What is the unconscious protocol anytime someone goes unconscious because of choking? Does that person still have a heartbeat? Well, initially they will, but it's compressions, right? Because compressions in that realm work to build up that pressure from behind the trachea, air pressure is built up, and hopefully that object gets to a point in the throat where you can actually visualize it and take it out. Getting kind of tangential and going off on certain topics, so I'm going to try and stay focused and just keep on our compression only CPR. This was pretty fascinating as well, right? This is the Arizona data from 2005 to 2010. Witness cardiac arrest. And we have enough information here to say, look at this. If they were doing no CPR versus traditional CPR, it's the same. So did you do anything? No, because you have to stop for those 10 seconds, give the breaths. Data that I have not seen, but I know is going to be part of that is, did the person vomit and then they started doing CPR and then they stopped? Because obviously you're not going to put your mouth on someone else's vomit. So just know for the appropriate setting that chest compression only CPR showed almost doubled the rate of survival for this. And that's pretty impressive. Now, your assessment may be a little different from what we're seeing here, right? Shake and shout. Hey, are you okay? What I would throw into the top of that, of course, is your PPE. Again, making sure you're safe. Scene safety is part of that. And then we check responsiveness, right? Checking responsiveness, tapping them on the shoulder. Hey, man, are you okay? And if there's no response, look at someone and tell them, hey, call 911, get an AED. What truly saves lives in that sudden cardiac arrest is the defibrillator. And defibrillators now are becoming so popular and widespread. You can go to the movie theater, you can go to the airport, casino. Well, you may not be able to do that today, but you can see there are a lot of places where AEDs actually are. This compression rate should be, and now I'm going to let you fill in the blank. What is the correct compression rate per minute based on AHA standards anytime you're doing compressions on an adult, child, infant? It is 100 to 120. 100 to 120 is our goal. But as we go through this again, we'll see that there are other parts that we have to consider. He's pressing hard, he's pressing fast, the body weight shifts down. It's almost like that. You gotta be older to know what this is. Maybe I can find a picture of one where you had the little bird that dips his head down in the water and then he springs back. They were very popular in the 70s. But that's the way I kind of think of compressions, because it's that body moving just back and forth. It's avoiding the accessory muscle use of your arms or hands. You really don't want the hands per se with the fingers. You want the heel of your hand, because that is by far going to be the strongest position that you can find. Rate and depth. Okay. At least 100 to 120, right? 100 to 120. And your depth, minimum 2 inches for an adult. Again, for an adult, we're looking at anyone past that point of puberty. A couple of the different songs here. Yeah, Staying Alive, We Got a Feeling. I believe Another One Bites the Dust is also closer to the 110 range, so that would certainly be appropriate. Just don't sing some of these things out loud while the patient's family is congregating around you. Another One Bites, yeah, might not be pretty. But no, we have to adjust that compression rate to what your current standards are. When you're assessing breathing, and as an EMT, we assess breathing and pulse together, right? It's a 10-second assessment, breathing and pulse. But the question we're really looking at here is gasping. You know, you go down and you open that patient's airway and you see this. Okay. Gasping is an okay term, but you should refer to that as an agonal respiration. As in an agonal respiration, that brain has lower levels of oxygen in it. It's truly just a reflex. So if you see that and they're not breathing just like you and I are right now, treat them like they're not breathing. Don't stop chest compressions if they gasp. Okay, that gasp is this last ditch effort for the brain to try and get some oxygen moving up to it. Just go to the AED. Yes. So the AED is your friend. The automated external defibrillator. Again, I referred to your skill sheet with that. That's something else that hopefully on Saturdays we can look at with Bridget. But then an AED is easy to use. And if I had a little kid here, I don't have small children, but I could take that AED and say, hey, can you make this work? And just to give you the idea, you can do the audio for it. AEDs tell you what to do.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light.
Okay. I did that.
Analyzing heart rhythm.
See what happens.
Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock now. Press the orange button now.
Everybody's clear.
Shock delivered.
Resume CPR.
Begin CPR.
So a couple of things with the AED is that's pretty easy to use, but there are some considerations with it. And let's look at this person's chest as we can start to think what some of those potential issues are. If there's moisture, right, dry it off. Electricity, water, right, not always the best combination. So that's why we stress this is going to be on a bare chest. A lot of times you're dealing with someone who may have a hairy chest, and I don't mean just a couple little hairs, right? You take off the shirt and your partner says, hey, did you take the shirt off? You're like, I did. Okay, those are issues that we want to shave. But please shave here and here. You don't have to shave the entirety of the chest. It's simply these two spots, or when we look at this little angle, something called Einthoven's triangle, that we're actually getting a good view of the heart. So the chest needs to be dry. It needs to be free from hair. If there happens to be a bra, that too needs to come off, because as we're assessing that patient and doing CPR, there shouldn't be anything on from the above the waist. So get that shirt off, cut it, rip it. AEDs do often come equipped with a nice pair of trauma shears in addition to the scissors, but that's where knowing your equipment comes in. You have to be aware of the equipment that you actually have. You can always use a second set of pads to remove some of that chest hair, but no second set of pads. You can't put a fresh set of pads on the chest, rip it off, and then have no replacement to put on the person. So once those do get covered with hair, they're just not going to stick. Now, different universal symptoms, or I'm sorry, symbols for the AED. Great, safe, easy, voice prompted. I wanted you to hear that. And if there's any questions with that, you'll have to let me know. I don't really think we need to talk about purchasing AEDs on there, but just a little information, come back, look at the review. So with this, hopefully it makes sense why compression only CPR is appropriate in that sudden cardiac arrest. Right? This is not something we're going to go out and do to the 6-year-old who was found at the bottom of the pool, right? They need their oxygen. There were also a couple of things that were missing from that, and part of your AHA that you need to think about: the team dynamics, right? How often should each person switch when they're doing compressions? I'm going to tell you that's just no more than every 2 minutes, right? But working as a team, having someone potentially on the airway, someone compressing, and then when you have it, bringing the oxygen on board, right? But that's changing to your professional standards versus a way you may be more likely to respond as a lay responder, or even as an off-duty paramedic. If I see someone walking down the street and they just eat the pavement, I'm going to do compressions. So hopefully this was informative. You had some fun just kind of answering the questions as we went along, and we'll see what we can't put in store for you guys in the next couple of days. But thank you.